Hi, good afternoon. We're going to wait just a minute or two. We got 25 people logged in. We'll give people another minute or two to get settled. All right, it's 12:01. I'm going to kick us off. My name is Cecily, and I am a proud UC Berkeley Public Health alumni, and I am co-hosting this webinar, which is titled "A Discussion About Disability as a Public Health Issue, Inclusion, Impact, and Measurement." And next slide, please. Thank you so much, everyone, for joining. We have 42 people already, which is remarkable. And the purpose of this webinar is to start a discussion and raise questions about disability as a public health issue. In case you can't tell from the photo of me on the notification for this webinar, I am a person with dwarfism and have been affected as a patient in the medical system, and I also work in public health. And as a board member of the School Public Health Alumni Association, I wanted to host a webinar that's accessible to as many people as possible. The Public Health Alumni Association's mission is to connect UC Berkeley School of Public Health alum and students to increase the advancement of public health practice, leadership, and health equity. And I'm going to pass this along to my co-host, Alva, and our fabulous student mentors who are examples of leadership and health equity. Alva, can you introduce yourself, please?
Thanks, Cecily. Hello, I am Alva Gardner, UC Berkeley class of 2013. I got my bachelor's in American Studies, focusing in psychology, art, gender and women's studies, and disability studies. I am a woman with a disability called cerebral palsy. My visual description, I'm Caucasian. I have brownish blonde hair that's pulled into a ponytail. I'm wearing green glasses, a blue button-down shirt, and I have a decorative shelf behind me. Um, and I'm here to share my lived experience as someone with a disability in the medical space and appointments and how ableism really plays into that.
Thank you so much, Alva. I can introduce myself next. My name is Andrew Minor, he, him, his. I'm a Master Public Health student concentrating in health policy and management. As someone with a close family member living with a disability, this topic is very important to me, and I'm very grateful to be part of this conversation.
Thanks so much, guys. Hi, everybody. My name is Jenny Yang. I use the She series, and I'm a second year undergraduate student, also majoring in public health. I'm also doing minors in disability studies and public policy. I serve as this year's ASUC senator, specifically for the disabled community, which is our undergraduate student government. So it's been amazing just hearing and doing community work for the disabled community. As I live with like a milder version of cerebral palsy. So yeah, it's been great and I'm excited to be in this conversation. So if we move to the next slide, we wanted to pose a question to everybody in the chat to share like an answer to what is ableism. And so I'll turn it to Alva and Cecily. If you want to give your definitions first while we have some answers rolling in the chat, that'd be awesome.
Sure. So, yeah, so there are many definitions. If you Google ableism, you can probably find 20 different versions. But the one that I particularly like and use in my work a lot is a quote by Talia Lewis and Dustin Gibson via Rebecca Coakley. And it's the part I want to highlight is it's a system that places value on people's bodies and minds based on societally constructed ideas of normality, intelligence, excellence, desirability, and productivity. And part that I find really interesting about this definition, often don't see in other definitions, is it ends with you do not have to be disabled to experience ableism. So while Cecilie and I are definitely going to be speaking about ableism from a disability perspective, I think that's really important to highlight and to acknowledge is that disability is not the only category of people that can experience ableism. And when we talk about public health, the medical system, it's easy to assume, or really anything with disability, it's easy to assume that it doesn't apply to you, that what's being discussed doesn't affect you. And, in addition to recontextualizing disability, I always like to throw in that disability is the largest minority group in the world. It is the only minority group that anybody can and probably will join at some point throughout their life. And so it's really critical to not remove oneself from the identity of disability, because just because you don't identify with that label right now doesn't mean that you never will. And so when we talk about ableism, we want to be sure that we're conscious of the fact that ableism can affect anybody, regardless of their disability status in this current moment. And then we want to talk about, so there's two models of disability. There's the social model and the medical model. And for the purposes of this conversation, we'll focus on the medical model, which is that states that disabilities and people with disabilities are the problem in the equation. People with disabilities are the thing that needs to be fixed, or the thing that is broken. So the issue, the challenge, the problem lies with the person. And before I hand it over to Cecilie to talk about ableism specifically in public health, I want to just say, we didn't say this at the beginning, there is a Q&A button at the bottom. So if you have questions, please put those in there. Our moderators are checking that for questions, and they'll be voicing those at the appropriate time. Cecilie?
Do we want to go to the next slide for examples of ableism?
Well,
And are there...
Do you want to talk about ableism in public health first?
Sure. And are there any definitions of ableism that came into the chat?
Yeah, there were a few that I wanted to highlight. So the first was that ableism is a worldview that excludes those who are differently abled than we are. So that's definitely valuable insight, and I think it's something, yeah, thank you for sharing that. And then another thing in the chat says, could we say that one aspect of ableism is assuming that everyone is standardly able and not planning for ways to include people with differences or disabilities? So yeah, those are kind of the other questions and comments that we had in the chat. But thanks for those who were shared that. Thank you so much.
Yeah.
So this next question, and really the next two questions, are examples of ableism in daily life and examples of ableism in a public health setting. And the two are related. You know, in terms of ableism, I like to think of attitudinal barriers being the most challenging, where people just don't take you seriously and will point. A lot of people with disabilities will have their photos taken. They will be ignored. If you're with an average sized person, the average sized person will be asked what you want because you're disabled, so you don't have a functioning brain. It's a societal, unfortunate ism. And when you combine it with other minoritized groups, such as seniors, people of color, the effects get magnified, which is one of the reasons we're highlighting it here. And in terms of ableism and public health, which is our next slide, I want people to start thinking of examples and putting them in the chat, or if you have questions, asking them in the Q&A. Ableism in public health has many forms. For me, you know, it was my experience of, you know, living as a person with dwarfism. The first is just attitudinal barriers, that you are not an informed person when it comes to your health, and the decision will be made for you, not shared decision making, but well, this is our protocol for dwarfism, and this is what we're going to do. There's over 200 different types of dwarfism, and everyone is different. Some people have all of this common side effects. Some people have very few. So this attitudinal issues, that's the number one. The other is, quite frankly, the physical access to the office. Can you get on the exam table? If you're a wheelchair user, is there a scale that will weigh you? This is the hardest one. And I'm going to give an example. And if you are a person with a disability and have experienced this, I am sorry. And we can also discuss examples in the chat if you would like to share. But it's finding a primary care physician, finding a PCP, and staying with that PCP. Because when surveyed, unfortunately, medical providers feel people with disabilities are less than. They have negative attitudes. And if you do some research on your own, you'll see they don't see lives of people with disabilities as worthy as people without disabilities. And this includes hidden disabilities as well as obvious visual disabilities, which Alva and I have. And that makes it hard to find a PCP. You will often hear people say, a provider has told them, you're too complex for me. I'm not the provider for you. And there is an example of that. It's a well-written article recently, is 2021, about primary care providers and their attitudes towards people with disabilities. So you have a hard time finding that PCP. In medical school, there's not a lot of training on reasonable accommodation. So in the medical system is not always disability competent. And what I mean by that is, do you know how to transfer someone to an exam table? If you have joint issues, are there orthopedics exams that are just not safe for you, that will injure you? Is there training on and support? So the providers, they start out with this, and there's this vicious cycle where unfortunately the providers start out with this attitude, they don't get the training, they don't get the office support, and they want to help patients. And they're frustrated, but they're also afraid of being sued because they can't provide the good care in the system yet. So the ableism, which is the hardest part, is finding a primary care physician, or even, has anyone had to go to a physical therapist's office and there's no elevator, it's just stairs up to the office? It's structural and it's attitudinal. And then specialists is another issue, which follows up on the first one, where, if, as Alva said, people with disabilities represent 25% of the population, but there are many different disabilities that exist, and there's no training on each one of them. The resources, accurate resources, are hard to find. Finding a specialist, you're going to wait longer. You may have to go out of state. And I am toward the end there. I have some ideas and solutions for this issue, but it's harder to find somebody who feels comfortable treating you. And then you get experienced care delays. And the last ableism, I'm hoping we're getting a lot in the chat as I'm talking, is something called diagnostic overshadowing. So it's diagnostic overshadowing. So that you, as Alva said, your disability dictates your care plan. I could be a brick. I could be a paperclip. I have this diagnosis. Everything cascades from that. So if I, but the diagnostic overshadowing is if anything happens, oh, it's because of this pre-existing condition. And it may or it may not be. And what you end up with is people go to the doctor, my arm hurts. You're a dwarf. It's okay. Expect to have arm issues. Well, actually, the person had a broken elbow, but the person was not given an x-ray because of this diagnosis. So those are there's, as I said, ableism in public health has many forms. I'm wondering what we're seeing in the chat on this topic.
Yeah, we're getting a lot of great comments from our audience members. Erica, I think is speaking to the challenge of diagnostic overshadowing to some extent. They mentioned that everything comes back to your first condition. There may be a lack of listening, right? On the part of providers that needs to be addressed for people living with disabilities. Diana also mentioned that there's a strong focus on prevention of disabilities rather than accommodation, and a need for more research into their lived experiences in the academic sphere. John also contributed something very valuable. He pointed to a valuable kind of academic debate underway around how national health surveys are collecting data on disability by Scott Landis and Bonnie Lynn Sweener. It's a very kind of valuable study that I've actually heard about, questioning how the NHIS National Health Interview Survey, right, is evaluating, right, its disability questions and how it threatens the ability of the survey to fulfill its stated objective for disabled people more broadly. So thank you so much, John, for sharing about that particular kind of discussion that's underway. Diana also added a really great point about how health experts often ignore lived experiences of people with health conditions. Then later, those lived experiences are given credence because a study was done to validate them. And then Sabrina, echoed similar frustrations that around how our health system is failing to treat women and people with disabilities too. So those are just some valuable insights that were shared in the chat so far.
And that's actually a great segue. I was going to add something, as a sub point to what Cecilie shared about specialists being even trickier. As a woman, and somebody shared this in the chat, female reproductive health is a whole other can of worms that often leads to an even higher level of ableism, right? Whether that's providers assuming that women with disabilities can't get pregnant or can't carry a child, can't go through labor, things like that. That's a whole other. We could do a whole other episode just about that. And I share that as my husband and I have just started our reproductive journey. And so that topic specifically is very front of mind for me these days. And I think what's really critical to remember and acknowledge is that in any of these scenarios where somebody with a disability is experiencing ableism or discrimination of any kind in a medical setting or just in their life, is acknowledging that the burden that places on us to have a much higher level of self-advocacy and comfort with pushing back against the ableism that we're experiencing on top of whatever medical condition or issue that you were there to see the doctor for is exhausting, right? If you go in because you are in pain or you don't feel good, you're sick in some way, fighting a doctor to listen to you is not what you should have to do. So that burden, and I genuinely think it is a burden of that added pressure, that added self-advocacy that we are required to express and exhibit is a whole other magnifier of the ableism that we experience and the impact that ableism has. I think that's a really important distinction is, yes, we're experiencing the ableism and we're combating the ableism, but what is the impact that ableism is having, and how have we had to also fight against the impact? I think we're ready to go to the next slide.
I'll take this one. And some examples of public health metrics that are biased against people with disabilities. I encourage you to put some of these in the chat. See what we're getting. Is there anything in the chat now, or should we go to the next slide? Because I actually listed some.
I'll go ahead to the next slide. Nothing in the chat so far on this topic.
Okay. So the first one, and I have a space between the first one and the ones below on purpose, it's lack of reporting. And I'm going to give an example of this later in the presentation, just not being included at all in metrics. So if you're looking at mammograms, you'll see by social determinants of health, you'll see race, ethnicity, zip code. Is there a category of people, wheelchair users, who don't get mammograms because the machines are not wheelchair accessible? I personally have known women who have gone decades without a pap smear because their medical providers don't know how to do it. And they just kind of unfortunately give up. And cervical cancer is, no one should be, should experience that, and it's preventable. But just the disparities, and again, as was the first metric, the question is not being asked. They're not being included in the metric. And in order to fix something, you need to know where to fix it. And if you don't have data that tells you what's going on, you can't fix it and you can't know if it's being improved on. So that's an example of disparities. And as Alva pointed out too, it's also women in public health that, they're not being listened to. The next one is if anyone's ever been, if we have people over 50 or if you've been in rehab, activities of daily living surveys. There are questions on that survey that may unfairly rate the quality or life or capability of a person with a disability. And ADL surveys are used for many things, discharge from a rehab or, whether or not you need extra personal care attendants at home. One of the questions often on that is, can you go up a flight of stairs? Maybe you've never gone up a flight of stairs. That doesn't mean that you don't have a quality of life. It's like asking a penguin if they can fly. Yes, they're a bird, but their ability to fly does not make them a successful penguin. This one, the next one that, and I'm hoping as all of my public health people are thinking of metrics, and I want you to think of the metrics you use often and say, is this largest minority or minoritized group included in it? This is one is called quality adjusted life years, or QALYs. A QALY is a scale between 0 and 1 that looks at the utility, how effective something is, and whether or not it restores you to perfect health. So, if you get 1 year and you go to, this drug or treatment protocol will get you to perfect health, it's a 1. But if it gets you to an unhealthy state, it's a 0.5. These qualities are controversial. In 2024, the House actually passed a measure, Republican-led House passed a measure to ban them for use in Medicare and Medicaid, to approve medicines and protocol, because as you think about it, as we age, we're no longer in perfect health. And if you have a chronic condition that you will live with but not die from, that's not perfect health, and the quality, that's an issue with the qualities. And as a follow-up for the 75 people on this call and everyone watching the video, I would suggest you research this more if you haven't heard of it. And an example of ableism, and one of the starkest in recent memory, is the quality of life surveys used to prioritize treatment during COVID, specifically who to treat and who to give a respirator to. So several states, including Utah, had written protocols that would evaluate your quality of life, and based on disability or obesity or, how many years you had left in life, you were prioritized to not have treatment. Santa Clara County, if anyone remembers this, there was a shortage of respirators, and they scoured nursing homes and hospitals for anyone who had a respirator, even a broken one. And they took the respirators and, redistributed them to places where they were needed. That's good intention. What they also did is ask people with disabilities who use respirators to report if they had a backup respirator at home. Why would they do that? That, to me, is one of the starkest examples of ableism. It's just, and the follow-up of this is that there was a huge uproar about, for example, deprioritizing somebody with Down syndrome from getting care during COVID. And most of those protocols that use quality of life to prioritize treatment were reversed. But, go back and read the news. It's still there. I have an example that I wanted to give, another one, but I want to see what's in the chat for these, if anyone's put any.
And before you give an example, I have something to add about the COVID stuff before we move on.
Go ahead.
So I think another big piece of the ableism that we experienced during COVID during the height of COVID, let me say, is of course when people would go into hospitals, whether for COVID or something else, other people were not allowed to go with them. And I knew several people with significant disabilities who had to be hospitalized for non-COVID related medical issues during COVID, who were denied that their personal attendants could be with them. And what that led to was an even higher level of inequity in care, because of course the hospital staff were so busy that they weren't able to support people with non-medical disability related things like taking a drink of water or adjusting a pillow or being able to push the emergency call button if they were in pain or whatever it might have been. And that's what a personal care attendant would have done for those people. But because people with disabilities were denied being able to have that support with them, it inadvertently led to other health issues being caused or even exacerbated. Excuse me. What are we seeing in the chat? Anything?
Yes, we are seeing comments in the chat. Thanks so much, everyone, for chiming in. Sabrina agrees that these are great points. Diana expresses, a very natural and understandable, distress at the types of examples that you're providing, in which our public health system is failing to account for lived experience of people with disabilities in the data and the metrics that are being measured. We also got a great quote provided by Leona May from Linda Mullally Hunt. Everybody is smart in different ways, but if you judge a fish by its ability to climb a tree, it will live its life believing it is stupid. A quote that really speaks to the challenges that both of you have been discussing so far for people with disabilities. John also provided another really valuable piece of research, or excuse me, a report actually from the NIH. It's basically a strategic plan for disability health research for 2026 to 2030. A really valuable planning document that John has linked in the chat in case anyone wants to view that information. And then Valerie expressed how eye-opening it is that ADA progress has been visible, say in the workplace, but gaps in the medical realm is still very apparent, and more kind of research needs to be devoted to identifying and addressing those existing disparities. And Leona May also chimed in with another comment just right now about how there's a search for a provider who is comfortable treating them as opposed to seeking a provider by whom they're comfortable being treated. And then Diana also shared about their experience during COVID, visiting their disabled mother in a skilled nursing facility, and their belief that if she did not have them as an advocate, they would have passed away sooner. Very appreciative, Diana, of your opening up about that very challenging experience. We really appreciate it. Those are the comments that have come in so far.
Thank you, Andrew. And
I was going to give an example of
yeah.
Okay, so I'm going to talk about everyone here, anyone work in public health, we know about patient falls. And I'm going to talk for just 30 seconds about patient falls, and then trigger warning, I am going to give an example of that, of where ableism did possibly cost a life, and just compare the two. So patient falls, a fall is an unplanned descent to the floor or an object or on another person. Patient falls in an inpatient or outpatient setting are tracked by everyone who works in quality. When you get admitted to the hospital, there's a patient falls scale. You will be asked questions. The patient falls scale is asked repeatedly to see if there's any change. And all the nurses and medical assistants, all the medical providers are watching you to see, can you walk independently? Are you gripping the walls? It's noted, it's charted. If a patient does fall, it is recorded and falls are counted. You're benchmarked against other facilities to see who has more patient falls or less. And you get less money if you have patient falls. It's preventable. This is an example, and these are tools. There are tools you get if a patient is assessed as a high fall risk. They might get a sitter. I mean, everyone's going to get the socks that have grips on them, but they're interventions, and people take it seriously. Trigger warning: you're going to want to mute for a minute if you don't want to hear this story. But this is. And I know some of my friends from LPA are on, and you may know this individual. I met a man who has a form of dwarfism similar to mine, and similar to me, he has a very short neck, which means the standard adult intubation kit is too big for you. You may need a pediatric or an adult small. He's an identical twin. He was an identical twin. He and his identical twin brother, lots of money, good health care. He was walking one day and he fell on a sidewalk, broke his arm, rushed to the ambulance, to the hospital. He had to have surgery to reset the arm. Now's when you're going to want to mute if you want to mute. And he went into cardiac arrest on the operating table, and he needed to be intubated. There was no pediatric-sized intubation kit in the OR. He died as the nurse was sprinting down the hospital with the right-sized kit. This is ableism on so many levels. It's preventable. And I said that I'm bringing up this example because one, I knew him and I just can't, we need to learn from this, but two, where anywhere in the world of quality is something like this going to be recorded in such a way we can learn from it and prevent it in the future? And in the chat, if you want, where could this intervention have happened? If you think about patient falls, when we know it can happen, there's so, that we want to prevent the falls, and there's so many points of intervention and documentation. How could we have saved this man's life? Real basic equipment. Could the ambulance driver have said, this person needs this size blood pressure cuff? Or, at what point during the warm handoff was this missed? And before he went under, did someone think, what is he going to use? And what tools do we have to help prevent this in the future? I know, the 2 times I've been in the hospital, I have advocated. And I know to do that. And I made sure there were 3 different size blood pressure cuffs and whole thing with intubation. I personally called the anesthesiologist, and they responded well. But just this goes on every day. And if the questions aren't being asked or tracked, what do we do next? Before we go to the next slide, if there's any comments from the audience or fabulous 70 plus people.
No questions from the chat, but obviously everyone is very devastated, right, by that story that you shared. So thank you for that.
Thank you.
Go ahead, Cecilie.
No, I don't have anything.
Oh, but did you have anything to add? Or
I can add it at the end if there's a question. Go for it.
Oh, there was no question. I was just gonna probably move on to the next one. But if you guys have something to share on this topic,
So yeah, I just before I move on, I think it's important to say that we're speaking predominantly in the medical, in like hospital, doctor, reproductive health, like that medical space. But I mean, this extends even into dental health. People with disabilities that have significant impacts to their mouth because of their disability. Even dentists will refuse to take them as patients, right? And so dental health is often very subpar in people with significant disabilities. That could even be with folks who are neurodivergent as well. And so, and as we know, dental issues can lead to bigger health issues as well. So it really is at every level of healthcare that this is an issue. Thank you. I think we can move on.
Next slide.
awesome. Yeah, so our next question for everyone that we want to pose is, what steps can we take to reduce AIDS? This can be in general or within the public health space. And so as everyone's typing in the chat, I'd love to defer that to Cecilie and Alva.
So I think the way I see it is that the biggest thing is we need to be talking about ableism. We need to be talking about disability inclusion in these spaces. Um, Disability in general has such a taboo surrounding it. And unfortunately, in our current political climate, that taboo and that fear of even saying the word disability or inclusion or access is even more heightened. And when things don't get discussed, don't get acknowledged, don't get, worked on as a group, they perpetuate. So we're seeing, starting back in COVID, we're seeing even higher levels of ableism, and largely that's because it's not being discussed, it's not being included in metrics. I didn't study public health, so not, I don't know a lot of the studies that get talked about around this topic, but I'm ecstatic to hear that so many of you are listing studies that are being done around disability, around ableism, inclusion, etc., in public health space. I think that really is a monumental step that we can all take towards reducing ableism in this space. That's what you want to add, and
Yeah,
we go to
and
the
just
next slide.
I have one example before we go to the next slide, and
Okay.
I'm hoping we have time for questions. But what I have learned over the decades in a successful pregnancy, even though I also was told that it was way too dangerous for me to have kids, and that was not the case, is I do two things when I go to any provider. The first is I prepare and get a good referral. I bring somebody with me, and when I prepare, I also bring a one-page handout that lists what is safe for me, and just a little information. I'm fortunate that I work with a lot of wonderful nurses, and they help me write it in the right words, and it's got to be short, like one page. Then I bring three copies. Three. First copy, when you get in, you hand to the medical assistant and you ask the medical assistant, can you please scan this into my chart? They scan documents all the time. Yes, I know it's 2026, but we're still scanning into medical charts. The second copy you give to the medical provider when they come into the room, and you say, hey, here's some information about my rare condition, and I already asked the medical assistant to scan it to my chart, but here's a copy for you. And the third you have with you, you have it out with whatever written questions you may have. So it's conscious because people are busy, and it's a lot to remember what's what. I mean, nobody wakes up and says, I'm going to cause patient harm. It's not. It's hard to be on the front line. And on that note, what I do when I go to a provider, especially a new one, if you have the means, go to Trader Joe's and pick up a bag of oranges, or bring the frontline staff a bag of Hershey's Kisses. A simple thank you and acknowledging how hard they're working goes a long way. So that's sort of my, what I have learned works for me. And are there any questions in the Q&A?
While we wait for questions, I think I'll just add, in addition to what Cecily does, I also usually bring my husband with me. I we almost have to pre-prepare for the questions that we think we're going to be asked, and be able to nip them in the bud before they get asked. So I recently, as I shared, my husband and I are on our just beginning our reproductive journey, and when meeting with new OBGYNs, I know that as somebody in a wheelchair, the first thing they're going to assume is that I can't walk. And so one of the things I say when I'm basically introducing myself is, "Hi, I'm Alva. I have cerebral palsy. By the way, I can walk." Because they don't ask that. They see wheelchair and they assume you can't walk. So I think it's also about kind of thinking about how the appointment will go beforehand and being prepared to say the things, share the information that they probably won't ask about because they'll see you and make assumptions and so not even bother to ask the questions.
Thanks so much for your guys' insight. It was super helpful, and there's a ton of different comments and questions in the chat. Should we save like the questions for the end, or like what do you guys prefer? How do we want to go about comments and stuff?
Yeah, I mean
Um,
we're basically at the end, so maybe
Awesome.
Cecilie, do you want to speak to the next slide real quick?
Well, somebody beat me to the punch on the next slide. Let's do the next slide and then
Okay.
talk about our questions. But
Yeah.
be a voice. I mean, the fact that we had over 70 people here today is huge. We have lots of voices. Training for medical professionals who treat people with disabilities or complex medical needs, and this includes hidden disabilities that we haven't talked about as much on this. Inclusion, public health metrics, so we can track the progress and provide support when needed. And attitude, empowering people with disabilities, as Alva said, to successfully advocate for themselves. And that means packing your patience. And healthcare is hard enough, as Alva said. You have this added burden of, am I going to get correctly assessed? One example is if you're having an echocardiogram and you have a curved spine, the technician needs to change how they do that. If you're informed, you can say, hey, by the way, I have this condition. Here's how you need to do this routine exam on me. And then watch what they're doing and see if they don't have the wand at a 90-degree angle when you get your echocardiogram. An echocardiogram is a scan of the heart. And the last thing is community, the disabled community. There are lots of places online where you can, and our contact info is at the end, feel free to reach out to me, where you can reach out to people and get tips and tricks and just suggestions on how to handle situations.
Awesome. Thank you guys so much. And then that entire conversation sparked a lot of different questions. So as I'm scrolling through, the first one is, do you know of any checklists or tools a clinic or healthcare provider can use to better help their facility be better prepared for people with disabilities? And then on top of that, another follow-up, is there something we can share with providers to help them be more aware and adaptable as they continue training for in terms of like disability inclusion?
Cecilie, do you know of that?
I'll take this one.
Yeah.
If you go to the last slide, Johns Hopkins, there are some disability. So the Johns Hopkins Disability Resource Center, I don't know if they have a checklist per se, but as a next step from this, I'd like to write one that's very easy, fewer questions, the better, using non-ableist language, that somebody could program an Epic. Can we see a raised hand if we have any Epic electronic health record programmers out there? Like it, with the example of the person, who broke his arm, there had been a disability checklist. There would have been a place to intervene, having the right size intubation kit in the OR, in the operating room. So no, I don't know of one per se, but I love the question. And that was why we did this webinar, was we wanted to ask these questions. So thank you.
I will also just add, shameless plug. I do public speaking for medical professionals specifically to talk about these types of things and what they need to do to be prepared and set up for accessibility. So
Awesome. Thanks guys so much for that insight. And then the last question that was posed in the chat is directed to Alva. So it says at the beginning you described your appearance and your setting. Do you do this if there happen to be visually impaired participants? I present often and there have been visually impaired audience members. Is this something I should do or should I do something like that?
Yeah, so I do that before any and every speaking engagement I do because um you never know who is in the audience and um whether they are low vision or blind, or I've had instances where people join by phone and they just aren't seeing me. So yeah, I start every keynote training, webinar, whatever it is, I do with giving a visual description because I think that's a really unobtrusive and easy way to create an inclusive space from the get-go.
And one of that brings up an important point about accessible formats for medication and discharge instructions. If you are low vision or blind, if you're asked ahead of time, this is preparation. 5 Ps, proper preparation prevents poor performance. If someone needs large print, there's still many people who use Braille or your discharge from the hospital, the discharge instructions are so important. If you get it at a format you can read, or if your partner who's caring for you is disabled, but they can read, is really important. And one example of ableism, and as Alva mentioned, the whole minefield of ableism and reproductive health. There was a mom who was on WIC, Women, Infant, Children. She was having trouble mixing the formula for her baby because she was blind. She couldn't see at all. And she was given pre-mixed formula. Problem solved. So the accessible formats are very important, and that should be part of the toolkit. If you have arthritis and you can't open the pill bottle to help ease your arthritis pain, for example.
Yeah. And I think that you bring up a really good point, Cecily. That's not only if the patient is the one with the disability. My husband is able-bodied, but I am his emergency contact. I'm his medical support system. So he, a few months ago, had a medical emergency, and I had to navigate getting his documentation in a format that I could easily pick up, flip pages, um, find the information quickly that I needed to know to support him. And the first 5 pages were his name, uh, uh, patient ID number, address, phone. I had to flip 6 pages before I got to the actual page that had what I needed to do in an emergency. So being mindful of also when it's the partner or the emergency contact who has the disability is a whole other aspect to this conversation.
We have time for about 2 more questions. What else is in the chat or comments?
No, awesome. One just came in. Someone had a question about addressing ableism in research and policy circles. Have you seen any good examples of inclusion in these circles and what made them different from others? I'm interested in how climate change affects the disabled experience and would love to learn more about how to recreate those environments during researching climate action planning. This may be more reason, but let me know if I can make any clarifications. So basically, like the question is, have you seen ableism in research and policy? And how can we make those spaces, if so, more inclusive? And then another question that came in was, what are ways to support a friend or family member with a disability when it comes to healthcare or in general? If anyone wants to answer those two.
Those are great questions.
Do you want to answer the first one? That seems like you're
The research one?
Yeah.
A lot of people with disabilities have awesome senior thesis dissertations addressing these questions. As far as research in the medical field, if anyone knows of any, let me know. I've seen some great individual examples, very small. That's the whole point of doing this webinar, is to start asking the questions and have that be part of public health research. It's just the lack of metrics. Alva, you want to take the next one?
Yeah. Jada, I'm sorry, can you say what the second question was again?
Yeah,
Okay.
sure. So the first one was about like ableism within research and policy spaces, and how like we can be more inclusive there. The second is like, what are ways to support friends or family members with a disability when it comes down to healthcare and supporting them in that space or just in general?
Yeah, thank you for the reminder. So I'll just add to what Cecily said. I think the biggest thing is we need to be including people with disabilities in research settings. So, like we've said, so often we're not even included in those research studies. So, of course, our input, our experience is not being captured. So I think that's a really high level thing that's missing. And then in terms of what family and friends can do, I think the biggest thing you can do is ask the person in your life what supports they want or what supports they feel like they need. Or what about this specific appointment is making them nervous or are they worried about, right? When I go into an appointment with a GP, I pretty much know what ableism I'm gonna face potentially. And so I know how to combat that. I know what questions they're likely not going to ask me that I need to just speak to. I know what inappropriate questions they might ask me and how to respond to that. You know, when my husband and I had, we actually had a preconception appointment this past Friday. I've never been in one of those before. I had no idea what to expect from that appointment. And so the support that I wanted from him was very different. It was, you know, be my partner when ableism comes into the conversation, right? Know that we are on the same page when it comes to our goal of growing a family. You and I know how my body works way better than this doctor who has never met me before. So we both need to be able to speak to the ableist questions that do get asked and the necessary questions that don't get asked. And I just wanted to say hi, Dory. I forgot you were here. So,
And we're at time. This has been phenomenal. Thank you, everyone, for joining. Thank you especially to our student moderators and the School of Public Health Alumni Association for supporting us. And the last slide, I think, has our contact info. You have questions.
Yeah, and thank you, Cecilie, for inviting me.
Oh, thank you. This has been a fabulous hour. I appreciate everyone for coming. Forward the recording on to people. If you're watching this in the recording, thank you too.